his teacher, and I think Daniel is his student.
Oh, good.
They both are there in today's meeting.
Actually, he is a student, means he was in preventive medicine, MD student. Just like Mahalakshmi in pediatric surgery. He has come from CFC Vellore.
Oh. Danny, you want to switch on your video and say hi to sir? He's here.
Hello, Dr. Arun Daniel. How are you? Where are you?
He is hidden under the screen.
Sir, I'm fine, sir. I'm just in network problem, sir.
Thank you, Arun, for coordinating and your support. Thank you.
Thank you very much, sir. Welcome, sir.
$2:59. Shall we start? Or?
Shall we start?
Okay. Yeah. Good afternoon, friends. It is Friday afternoon and it is 3 p.m. We are back with one more episode of our Forefront of Future Frontiers, the medical webinar series. Today is series 14. That's on the theme of priority areas in public health. And today episode number 85. So we have explored evidence-based public health. We have explored the various public health delivery models in India and what is being done to ensure that there is equity in access to healthcare. So these are some of the topics we have explored. And keeping up with this theme, today we are going to talk about national strategy for TB elimination in India by 2025. And we have with us Dr. Anil Purty, who is Professor and HOD of Community Medicine, and also the Registrar from PIMS. So I request our Dean Sir, Professor Kotur, to welcome the speaker and share a few thoughts. Over to you, sir.
Very good afternoon to Dr. Anil Jacob, today's speaker for this FFF platform, and also the distinguished participants. And this is the, as Professor Mahalakshmi said, this is the 85th episode. We are heading towards the centenary celebration in another 10-15 episodes, and it is indeed a credibility established by our institution in the past almost 2 years, which was started when the COVID struck us, and certainly it is now we claim that it is one of the best practices of AVMC, this platform, and of course we have obvious outcomes coming out of this best practice as well. And I'm very proud, always say, and as I've said n number of times, this platform has been shared by eminent scholars, scientists, teachers of national and international repute. Now this today's topic is, of course, we have been having the public health issues addressed on this platform for the past couple of episodes. Now this today's topic, towards the strategy for TB elimination in India, is quite appropriate in the sense we all know that the National Tuberculosis Day is hardly 3-4 days away, just 4-5 days away, and in this direction, these 4 departments of our institution, microbiology, pulmonary medicine, general medicine, and community medicine, all have jointly planned to organize a series of activities, of course coinciding with the NAC visit also, which is happening during that time, and they are involving many other institutions in the city as well. We have, apart from the CME, PNMC accredited CME, they have quiz competitions, they have slogan competitions, they have posters presentations. So that's one very good activity we are looking forward during the next week, quite appropriate. And during this time, an expert in the field, Dr. Anil, will be sharing his experiences with this. being a community medicine man, certainly he has quite a lot to offer. And another reason why it is appropriate is we all know of the Sustainable Development Goals, which has aimed to accomplish elimination of tuberculosis across the globe by 2030. And our government, our especially Prime Minister, has been dared enough that 5 years earlier only we are going to eliminate the tuberculosis from India. And we also read them, 2021 target got failed or something. That also we read is all media things. Certainly, we have got another 3 years to go. Each one of us, if we realize that we have got to something to do for this, accomplish this goal, especially the healthcare professionals, including doctors, nurses, and all other folks, we should contribute and try to help achieve this target. That will be then whole of the world shall be looking towards India as what is done. Even though as it stands on today, presently we have a tuberculosis burden which is almost 27-28% of the global burden. Those many patients are here, so many are dying. The numbers are quite phenomenal numbers and quite shocking numbers, quite disappointing numbers. Millions of people dying. So this is the right time. At least AVMC also will definitely do its share in this, especially this tuberculosis day and all. Main intention is to create awareness and identify the patient, start treatment. So we have this year only we have got a seeds postgraduate program in the pulmonary tuberculosis. That is also an added factor for us. So certainly AVMC will be very happy to contribute its share in fighting this national or a global epidemic. These are some of the thoughts. Those are coming to my mind at this point of time. And Professor Anil Jacob, certainly he will be able to share his experiences. He can get us some more information which can fine tune us in the forthcoming not only this series of celebration, but as a whole for fighting this tuberculosis. And on behalf of our Honorable Chancellor, on the Board of Management and the University at large, and on behalf of all my staff and students, I am very honored and privileged to welcome Dr. Anil Jacob Purty for this Triple F platform. Thank you very much, Professor Mahalakshmi. Over to you.
Thank you, sir. I would request Professor Vishnu Bhatt, our Director Medical Research, to introduce the speaker. Over to you, sir.
Good afternoon to everybody. And our Dean, Dr. Kotu, Dr. Mahalakshmi, Dean HPE, Vice Principals, faculty members. Dr. Madhavan is also there from Venkateshwara, and all other learned people. It is a pleasure to introduce Dr. Anil Jacob Purty, who is Professor and Head of the Department of Community Medicine at Puducherry Institute of Medical Science, and is also the Registrar of PIMS. He is the Vice Chairman of National TB Elimination Program of India at present. He was the past President of Indian Association of Preventive and Social Medicine. He joined DIPMAR after completing his MBBS from CMC Vellore. He has been our MD student from Preventive and Social Medicine Department. Later, he did his DNB and also a PG diploma in bioethics from IGNOU. He has a lot of interest in the epidemiology, prevention, and control of tuberculosis. And I think they have rightly chosen him as the National Vice Chairman for the TB Elimination Program. He has done several studies on TB elimination, polio eradication program, national HIV control program, its control. So I was impressed by the way he was doing research in JIPMER and later at PIMS. several external projects he has got from WHO, DBT, DST, and ICMR, etc. And he has been selected earlier as a ICMR International Fellowship Program under Young Scientist Cadre, and he has been to Huber's Department of Global Health, then Rowley School of Public Health, CDC Atlanta, Johns Hopkins, National Institute of Health at Bethesda, USA. Almost all well-known institutions he has visited and underwent a fellowship program. He has been later sent to Brazil for Stop Tuberculosis campaign, and he has visited Nepal, Bangladesh, Sri Lanka, in addition to Edinburgh and Loma Linda University in USA. So he is well traveled. I think almost all countries in the world he must have seen. And he has been a WHO consultant for TB and HIV from 1999 to 2002. And he has been member of several academic bodies. He was assistant editor of a textbook of public health and community medicine released from AVMC. He has published several papers, and with all these externally funded projects, I think he is the right person to talk about control of TB or elimination of TB. We are not looking just at control, which is going on for years. And I think now we are looking at elimination of tuberculosis. So I think with all stalwarts in the team, we should be able to eliminate tuberculosis and make it tuberculosis control-free India. As Dean said, the major part of burden is in our country, and it has got so much issues with the region in relation to our economics and day-to-day living conditions. And I am sure that he will enlighten us on this topic. So back to Dr. Mahalakshmi.
Thank you very much, sir. Before we hand over the stage to Dr. Purty, I'd request the participants to keep themselves muted so that it is the audio quality is good for everyone. And for the information of participants, this program is being recorded and also being live streamed for academic purposes. So with this, we'll move over to Dr. Purty. Sir, you could share your screen and talk. Welcome, sir.
Good afternoon, everyone, and thank you very much, sir, for the very generous welcome. I don't think so I deserve many of those, but it is a great opportunity to be able to participate and be a part of this prestigious academic activity. And what's commendable is that it's going on, and this is the 85th in the series. Having been associated with several academic activities, I do understand starting is very easy with a bang and get everybody involved and inaugurated, but then sustaining it and keeping the memento and the quality is something that I think the whole team under the able leadership of the Dean, Professor Kotu, sir, along with the Director Research, Professor Vishnu Bhatt, sir, and Dr. Mahalakshmi, whom we know to be a very, very active and energetic faculty. Wherever she is able to spread that positivity and energy all around. And many other esteemed faculty who probably are part of this group. Arun Daniel, whom I personally know and have had the opportunity to interact. He is also from community medicine, and something that me and Dr. Arun share is playing music together, and we enjoyed playing music together. Well, coming to the topic today, as already introduced, I like to share that I'm also glad to be included as one of the members of the National Expert Committee, which is working towards subnational certification for TB elimination in India. And I'm grateful to the Central TB Division, Government of India, for kindly sharing their slides with me. And much of the data that I have been able to get is from what they have been able to share. What is this strategic plan? For perhaps those who already know, maybe a repetition, I'm sorry, kindly do bear with me, but I do understand there are also postgraduate students, and there are those perhaps who have not been directly linked with the TB control program. So you will have to bear with me with some of the basics that would find its place in this presentation. Now, the National Strategic Plan is something that the World Health Organization had been earmarking since the year 2015 for every country to put it down in pen and paper in a document that what does each country plan to do towards elimination of TB. And it took a couple of years, 2016, 17, and this is the first document. It's a huge document, widely available on public platforms, but I've just taken one bullet point of what does it say, that India has committed to be TB free and have 0 deaths because of TB, reduce the disease because due to there is a connection between poverty and TB. And to achieve this rapid decline in TB and morbidity and mortality in India, as already mentioned by our esteemed Dean Sir, India set up the target 5 years before the United Nations SDGs deadline for TB elimination was set, that is 2030. You know how difficult it is whenever you go to pick up somebody from a train or more commonly airport and the flight arrives before time. You know, we are also used to getting things on time and before time, which shows a huge commitment and an effort and also a lot of work. Well, what does it basically mean? Once this strategic plan is in place now, every year, starting from 2020, we are in 22 now, so 2 years have gone by, 23 and then 25. The basic measurements regarding TB that we use have the incidence of TB, the prevalence, the mortality, and also health economics have worked hard to put this figure down, because TB causes poverty, or poverty is interlinked to TB and causes a catastrophic economic loss to them. This should be reduced. Well, I'm just waiting for my slide to change. Slide.
Keyboard keys.
Yeah.
Hello?
Okay. Yes. Okay. So the thrust areas of this National Strategic Plan is to work with all stakeholders under the following principles: to treat in a multi-sectoral response, to treat MDR-TB, use computer tools, to active case finding, involve the private sector, which is a big sector, and to reach out to those unreached population. This would continue, and perhaps in the top of the slide is because I'm from a medical college and many of us in this group are directly or are affiliated to a medical college. Maybe I'll be sprinkling these presentations of what is the role of medical colleges, apart from many, many other important stakeholders who are also part of this endeavor. Now, this mechanism would continue during this period of the National Strategic Plan. There is a state task force in each state, Puducherry being one of them, and we're glad that we always have representation from AVMC and also VMMC Karekal, and we encourage each one of the team members in the medical college to support the respective medical college core committee to meet the indicators of TB elimination that are circulated or that are passed down from each one of them. Well, for medical colleges, the efforts to increase diagnostic and treatment services broadly are under these particular headings of seeing that there is provision for providing decentralized drugs for DRTB, drug-resistant TB. There is lab support for culture service. There are airborne infection control measures put in each institute. And definitely there is a system of surveillance and quality improvement apart from having private involvement and involved in research. I put research at the end, but I'm sure many of us in this group find research to be something as a motivating factor in getting involved in any program. There is an effort in order to improve the clinical services systematically and using specific indicators as we go along. I'll be sharing what is being done for each one of them and how there are quality measures to assess what is being achieved quantitatively, what are services that happen outside the walls of a medical institute, and we call them public health measures because it also has to do with a lot of measures that have a role in TB transmission in the community. That's where much of the TB spreads. In order to see that the program is effectively management, there are now systems put in place so that they become more efficient and respond to the required needs. With regard to diagnosis and treatment, dear all, I'm sure we must be aware about the increased number of CB-NAT facilities that are now available in possibly every medical college that we have. COVID taught us a lesson, and there were guidelines that each institute should have NAT-based diagnosis, but it has been also been recommended that we use molecular methods for diagnosis because it is not only more sensitive, but also more specific in the diagnosis. Having said that, there is a need to improve capacity for X-ray reading. So perhaps those of us who are interested, we could network and help in improvement of this capacity. There are groups now working on how artificial intelligence could be used to scan through chest X-rays and put up a diagnosis. I know IIT Madras is involved, VIT Vellore is doing some pilot projects, and there are a few other teams, I'm sure. So perhaps some radiologists in this group who are interested would like to participate. It would be a good time to pilot test this technology if computers can help wherever there is no human expert available. This could help in parts of India where a radiologist may not be available or somebody who can read an X-ray. In order to promote treatment, fixed drug combinations are now available, have really improved. It's also available with the private colleagues working in the private setup. There is a system to not only review, but also support them in their care of TB patients. The DRTB treatment, we do have a shorter regimen. Some of us probably are aware that there are still clinical trials going on to get regimens that are shorter than 9 or 6 months already. We need to wait to get a final result, but till then, from the conventional 2 to 3 years treatment that used to be part of a drug-resistant treatment regimens, we now have much shorter duration of treatment. We have drug sensitivity treatment, guided treatment. Bedaquiline is available now quite widely, and a few patients even in Puducherry have had access to this treatment. We'd like to thank all stakeholders, particularly Johnson & Johnson and other groups who made it possible for getting these group of drugs, which have been lifesavers, where patients, especially in high burden areas, particularly from hospitals, which first reported from Mumbai about a large number of patients dying of DRTB. There are various roles of medical workers, doctors, staff, and anyone who would like to support, including TB champions. And this is a new concept that has come up and we are using for TB patients who have been treated and cured and now would like to support. The program is providing appropriate measures, training, and incentives for TB champions to get involved in various aspects of TB diagnosis, treatment, follow-up, and support in many parts of the country. Culture services definitely have improved, and we look forward to all our colleagues from the Department of Microbiology to lead out in implementing standard methods of culture, which would help in drug sensitivity diagnosis, and treatment outcomes would improve for those patients who are resistant to TB. AIC is a much bigger topic. It requires planning, but with administrative and environmental support, AIC is and could be a measure to be utilized or to be implemented in each medical college or each healthcare setting in order to prevent the spread of airborne infections, including TB, in healthcare settings. Again, I'm just mentioning, we've learned a lot from the present pandemic, and I'm sure we can take forward the measures that we have already learned. There are public health measures that are in place and are being improved upon with regard to surveillance, local surveys, monitoring, and adopting of districts for intervention. And perhaps at the end of the presentation, I'd like to share what that could mean. Medical colleges need to be involved because medical colleges train the doctors of tomorrow. Medical and College of Nursing train them, have a large role in important training and sensitization and support to treatment and diagnosis. And therefore, their advocacy with support of the professional associations that they are linked with as part of their specialty need to provide support to the program. It is vital that medical colleges and faculty interested in operational research work towards developing common uniform protocols. We do understand what works in a situation X does not always work out well in situation Y. But when every time a group produces results based on their research from X, many times it's also duplication of what is being done by site Y. And perhaps in the program, it's being advocated if common protocols for looking of what is important to improve patient diagnosis, treatment, and follow-up measures, it would help in bringing out the issues and problems and help reduce the TB problem at much rapid rate. This is something that would be boring to some of you, showing some of the numbers regarding TB, but I put it here just to say what are the estimates that we now have of how many people, what is the rate of infection, incidence, and that translates, if you say 188 per lakh population. we do have close to 26 lakh individuals with TB. Significant of them also unfortunately die or succumb to the disease or comorbidities or other effects because of the infection. And while a lot has been done to control HIV, we appreciate the efforts being taken. There is a link between TB and HIV, and the program is over. MDR-TB, when we put them together in terms of the countries which are enlisted by the WHO, India is quite on top of the list. We do have MDR-TB, and we both have TB-HIV. And there are countries who have been able to work and control this, but I'm sure with the help and support of all, we can help in improving this. India has moved from the typical hard copy of report submission to an electronic system of reporting, which we believe is more efficient, timely, and we call that notification, where somebody responsible states upfront that this is a patient and he is registered with the program for treatment. We now look at the electronic platform Nikshay, and from the data that we have available in the national portal, and this has been published, is that there were these number of TB patients that were notified, 24 lakhs in adults, a little over 1.5 lakhs in pediatrics, and number during 2020 definitely has come down. And incidentally, this has happened in many parts of the globe, including Brazil, Russia, South Africa, from where we are working together to find out what is the effect of COVID and how possibly this can be circumvented. Again, from the online portal, probably in 2021, those numbers are, not as up, but we're coming to what was there in 2020. About 21 lakh TB patients have been notified portal. We will go by this information, although some of our colleagues could say that there are still continue to be TB patients who are not reportable to the particular portal in the system. I will agree with you, but there is now an active process by which this gap of what is not reported and what is reported is reduced to a much lower. There has been considerable progress over the past decade towards TB elimination with regard to the incidence of TB. There are various reasons why it definitely is curving down. It's not like any other viral diseases which show spikes and up down, but long-term trends show that definitely there is a decrease in TB, and the number of TB notifications are being increased. If you see this blue box over here, I'm not sure if you can see my pointer, but this number of missing TB patients, missing numbers, they're not there in the system, they're elsewhere, and there are methods by which this has been estimated by various studies. We have reason that definitely this number is decreasing from what used to be over 10 lakh to what is now a little less than 8 lakhs. More efforts need to be done, but we're glad this is already happening. At the press of a button on Nikshay portal, which every medical college has an access, the nodal officer can access trends for TB notification, not only in Puducherry, but anywhere else. And we invite our colleagues from pulmonary medicine, community medicine, microbiology to please use this data that is available to find out and to definitely ensure that the data that is generated from your medical college it finds its way in the portal there. The notification definitely has increased over the years. There is an increased private sector engagement over the year, and there are agencies like JEET available in number of districts which are supporting the TB control program. There are means by which the government of India has made TB notification important even in the private sector. All drugs that are being sold in counters have been put under the H1 schedule. There is an active collaboration with IMA and IFP and a national forum of professional associations, and TB notification is now made mandatory. So any of us involved in TB treatment and diagnosis, if you do not notify, you or me can get a notice saying why was this information not shared to the government portal. We do have a system in place of universal drug sensitivity and test, where every TB patient now being diagnosed has the opportunity to be tested whether they are drug sensitive, yes or no, upfront. There is a whole big program with program management of drug resistant TB or the PGDBE services. Now there are shorter regimens. I said it's about 9 to 11 months. And the number of patients who have been put during 2021 last year is about 865. So there are patients who continue to be in longer regimen, but this number with shorter regimens is now increasing. There are reasons to believe that outcomes among DRTB, which used to be quite poor, 50%, 48%, 68%, now is increasing to over 75 to 80%. So we see this as a hope for DRTB patients, which in the earlier years used to spell the death knell because patients used to lie hapless somewhere and drugs were too expensive or not available. We thank the efforts of everyone who's making this treatment possible in most, if not all, districts in the country. TB and HIV, the number of patients has significantly improved with regard to any TB patients who also have had an HIV test to know they are positive or negative and to follow them up whether they have diabetes or not. So both with the NCD program and with the HIV program, there has been a lot of close working together to find out what has happened. This is just being rolled out in many states systematically, where preventive treatment for the family members of any TB patients is being put in place. It's still low, systems are still not in place. We will need to work with this in the next few years. There are measures now being taken up for active case finding, and we request all our colleagues to support it in at least the surrounding of the medical college, at least in the urban and rural health center of your respective medical college that you are associated with as per the letter issued by the Central TB Division, Government of India. This is just to share some of the case finding measures that have been strengthened to improve in the public sector with regard to X-rays, to improving diagnostic algorithm, to having CBNAT machines right at district and sub-district level and PHC level. Also in the private sector, what I just mentioned, some of the measures that have been put in place in order to see that every patient also getting treatment in the private sector is registered so that the outcomes of what happened once treatment is started is readily available to the program. There have been number of gazette notifications with regard to this. And unfortunately, the government also has had to put in some penal provisions as per the penal code for those who may not comply with the notifications as per the Government of India order. So there definitely has been a shift in treatment of drug-resistant TB, and there are experts in this group and who can speak better than me, so I won't go into venture except telling that at least 7 states now have started shorter regimens in their country. And the number of injection-free treatment protocols that are now in place are being increased. They are in single digits in many states or UTs, but this is increasing. This is an important program where every TB patient is provided 500 rupees every month through direct bank transfer. And this has amounted to over 1,200 crores as of 2021 to support TB patients as they need to travel and they need and perhaps lose the wages on the day that they visit a hospital. There are also incentives for the treatment supporter, for the informant, and those who travel from a health facility to a TB patient for diagnosis, treatment, follow-up, or carrying a sample. Medical colleges, I can't leave it because medical colleges have a role, and we've divided the country into zonal and state task force in each state, and they work on the following topics or areas. I'm sure colleagues who are associated with that will be able to share in the medical college about what each one of them mean. There has been a very good contribution from medical colleges. Throughout the country, we believe 10 to 15% of TB patients are diagnosed, treated, and followed up in medical colleges. But for all our colleagues here in Puducherry, for Puducherry, it is twice that amount. In medical colleges in Puducherry, we happen to contribute 20 to 25% of diagnosis, treatment of TB patients in the area. Just to share some data for completion regarding what data is available from clinical versus microbiology confirmed TB, clinical versus microbiology confirmed TB, extrapulmonary TB, and pediatric TB. Again, because this data is available, I'm just sharing it because these slides will be available to anybody and you could utilize them. TB addresses several other cross links with the tobacco, cancer, diabetes, and other programs to which there is a cross reference. There has been integration with the Ayushman Bharat. There has been an interministerial coordination committee that has been set up, and several other sectors that are involved. Latent TB management is a way of looking forward. It would take a little bit more time in order to get there, but systems are in place to start latent TB, treatment of latent TB in the community level. The last section, and probably this is the latest, as we speak, this is happening around the country. There is a method of certification of district level or state level before a national level, before India is declared to be TB free by the WHO. There has been a commitment at the very high level, right from the PMO to the Honorable Health Minister, and the following state level commitments have been received from 2020 onwards that they would work to eliminate TB by this particular date. These are documented, and it's several activities are being carried out in each of the states towards each of these commitments made in order to eliminate TB from their respective states and UT. For those of us in Puducherry, you can see Puducherry here. So Puducherry also has made a commitment to eliminate TB and TB as per Government of India stipulations by 2025. There has been a progress towards it. How is this done? Now, every state or district submits the data regarding the reduction of TB incidence prevalence to the central government, and then in turn the central government in turn then requests the WHO through a method to assess first-hand information in that district and that state to find out whether the information that is provided is actually true or not. So there's a claim submitted. This data is then verified by an independent agency who is not state government, not central government, but an independent. And March 24th, which is around the corner, would be the date of the results being out. And those who have been able to get the data verified, getting the awards at a glittering function at Delhi. Compared to 2015, the numbers that need to be treated and what is a TB score, these are two attributes that need to be met before somebody applies. These data is available again on the NICSHI portal, and each one of them with regard to TB score, how much sales, drug sale is being met. Every pharmacy through their registers, community surveys are being made in order to find out how many TB patients are there and for each year. And at the end, a TB-free status is given if any state or district has a reduction of 20%, they get a bronze medal. Puducherry got this last year. Now, Puducherry has applied for a silver medal, which shows that compared to 2015, there has been a reduction of 40%. And then gradually going on to TB-free status, which is 60% and 80%. Just to share what happened last year, 2020 and 21, there was a claim from 66 districts and 19 states in the whole country. And there was an active team which worked in each of the districts throughout the country to verify the claims. And the faculty from medical colleges, particularly from community medicine, played an active role of working with the WHO. And this year with the ICMR, we're working to conduct each of these surveys as a third party to verify the claims that have been submitted. Well, at the end of that, all 66 districts could not get the medal because there were reasons why they could not be given. But what is encouraging is that there were districts, particularly UT of Lakshadweep is already TB-free. It's already TB-free. They circle over here down. Maybe it's easier for them. There's water all around, and so they're protected. And the following have got silver medal, and Puducherry here and Kerala have got the bronze medal. The key stakeholders in this campaign are everybody in the central government, WHO, ICMR institutes, task force involving medical colleges and partner organizations. And I've highlighted medical colleges because they're important in every district in the country. Medical colleges play an important role, and this is how they do and attend to their job responsibilities, which are laid down. And I would like to request and invite those who are interested, please join the team. Come, there's plenty of effort and work, and together I'm sure we can see and contribute towards the campaign that the government of India is working towards ending TB by 2025. I've just a couple of more slides. I know I'm 35 minutes up. And some notifications that have come to each of the medical colleges through the National Medical Commission about what should be done and what can be done in each of the states and each of the medical colleges. We request all of us to please take due cognizance of them and try our level best to comply with these stipulations of setting up ART centers, MDR-TB centers, collaborating with DRTB centers, and ensure availability of these facilities for treatment of patients in all medical colleges. There are challenges, dear friends, that there continues to be areas hard to reach, urban slums, migration occurs. There's a huge reservoir of latent TB infection. There are determinants outside the health sector, which we cannot really address. The quality of care in private sector perhaps is not always the best. There continues to be stigma and discrimination, and there is poor outcomes when it comes to treatment of drug TB patients. There's no one single answer, but there continues to be an effort to address these challenges. So therefore, the way forward, and this is the last slide, that we would need to work to transit from microscopic, direct microscopic to upfront molecular testing, improving general health system under NHM, a vulnerability mapping for active case finding, scaling up latent TB infection and management, scaling up private partners interface involving medical colleges, including private medical college, and important engaging with community and social organizations. It's time, dear friends, that we all get together to end TB. And I'll stop with that. If there are questions, I'll be glad to answer. Once again, thank you to all the organizers for this opportunity. And I'm sorry if I overshot my time.
No issue, sir. I think you are bang on time, and that was a very nice talk. And if I were to see the responses in the chat box, there are quite a few things. And one more person who has joined today is Dr. Can. So he has also congratulated you on taking up leadership level in elimination of TB at national level. Sir, one doubt when I was seeing your slides, there was one slide before the WHO data you showed across countries. It said that India hosts about 26.2% of global incidence of tuberculosis, but our mortality rate was 33.28. I do not know whether I misread the statistics. Is it 33.28% of world mortality or 33.28 of our own patients' mortality? I couldn't make out from that slide.
Yeah. Thank you very much. Thank you. That is just a global data with respect to the percentage contribution of total number of TB patients. So definitely 25 to 26% is the new cases of TB cases that were diagnosed in that year of which the global health report said. And of those deaths, so many number of deaths due to TB in India. So it is among the TB patients who were diagnosed in India, 26%. We have reported deaths, which contribute to 33% of the total deaths. The death rates in India continue to be high. Of course, I will be careful what I say because you are recording this information also. We know death records are not always verifiable, and always there is scope for improvement. And we believe that wherever there has been an audit to see if there was a TB death, groups have found out and widely published of how we could improve mortality data with regard to not only TB, very other illnesses. So, but that's the best that we have regarding mortality because of TB. But on the other side, definitely the number of deaths, what used to be reported earlier, and the number of deaths that are reported now has significantly come down. That is a fact. But whether it is exactly only 33% or little more than that, more work needs to be done in that area. Thank you.
Thank you, sir. Actually, you also touched upon a lot of quality improvement measures with regard to management of the program itself, like starting from improved diagnostics, getting artificial intelligence into diagnosing X-rays, and bringing out fixed drug combinations, etc., etc. All this actually again is hinging on data, and I think our Dr. Narayan has got a question. He says, how do we ensure that there is no underreporting, misreporting, falsification? What all are the steps taken to ensure data quality in this project?
Yeah, thank you very much. Thank you. So nice to have you, sir, Professor Narayan, sir, and whatever little that I've learned under his able guidance with regard to computer technology and working with data was because of his efforts when he encouraged us to work on ourselves. No spoon feeding, do it yourself. Now, well, having said that, definitely the electronic based data that we now are collecting at each medical college level and each PHC level has a system to prevent duplication or error. On the other side, if a data is missed out, if a data is not entered at all, the system that we have now in place or that we are trying to develop is to collect from other sources. Number one, every private practitioner also enters TB patients need to get the treatment somewhere in the district, somewhere in the state. So either they're going to the public care services, which let's say for our discussion caters to 50 to 60% at least. Now the treatment is free of TB patients, and probably the rest go elsewhere, including private care providers. Now, private care providers also have improved in reporting digitally to the NICSHI portal significantly from the data that I presented. Well, I must also share in this group now as teams are going house to house. And may I just share, in order to do a sub-national certification for Puducherry and the 216 districts in the country, as we speak, this work is going on or has just been completed day before yesterday in 2016 districts in 30 states of the country. Massive work. In each district, a population of 10,000 households have been covered by house-to-house mapping, actually. And looking at GPS data, looking at house-to-house correlates, we believe the data that has been now collected as a third party is very good, if not the best. There couldn't be any other method that is done. We have a system there of deduplication. Whether a TB patient was missed out, yes, no. And I shouldn't speak right now, but by 24th, you'll know if there were states or districts who perhaps could not get a award because the team found out that there were data that was missed out or there was duplication of data, and therefore the percentage indicators for reduction in TB have not been met. So this is another method by reinforcing that we need clean data. We need improved method of surveillance, which is coming about and is improving in our country. We've definitely come a long way from hard copies of TB reports, and they used to reach late, and a lot of duplications could be there. But now when there are state governments, there's, I believe, healthy competition between districts and district authorities to try to get this medal. 35 lakh rupees for a silver medal is quite motivating for any district or a state. And hopefully there would be improved compliance with regard to data sanctity or data, and would help in improved data management in our country.
Thank you, sir.
But I'm sure Dr. Narayan sir also will have many more better ideas of how to do it. I'll be contacting him perhaps later in the evening or tomorrow to speak to him in this regard. Thank you.
So cancer always has lots of ideas about everything. That is this thing. And there's one more thing, like, which is burning question in all our minds is when you showed the graphs, no sir, the trends were increasing, the number of cases and all that. And for the last 2 years, your graph was showing a dip. 2020-21, the number of cases reported. And so the question in the chat box from our Dean, Dr. Kotur, and from Arun Daniel is, what exactly happened during COVID pandemic? The cases really, and the deaths really increased or decreased? Did actually COVID make the TB problem worse or made it better?
Yeah, thank you very much. That's a very important and loaded question. And if I say, I don't know the answer to all of them, but yes, what we know, because we are at present working with the BRICS collaboration, Brazil, Russia, India, and South Africa under this collaboration, and with the funding from Department of Science and Technology, of looking of the data in our country and each of these countries of how the COVID pandemic has affected the diagnosis of TB patients. And there are scientists who are looking at the genomic makeup of both the COVID viruses and the strains. We know that of what was Omicron and what is Delta. I didn't know about this 2 years back, but we know more about the strains of TB bacteria, and there is some genomic correlation being established between them to find out whether they had a role or not. But the fact remains, in globally and at least data available for from each of these countries, there has been a decrease of over 50% in terms of TB patients that were diagnosed generally during 2020-21. The reason that we have seen, at least in parts of South India, at least in Tamil Nadu and parts of Puducherry, because any patient who coughed in the past 2 years would be subjected to a COVID test and sent to a quarantine and center. So wherever we've looked at active case finding, the first answer we'll get, no cough, nobody has cough, nobody has any symptoms. So that could have been a real reason why even symptomatic patients were discouraged from attending or diagnosing a facility. There are researchers who now are reporting that we could see an increased number of TB patients in 2022. And in the first quarter, January, February, March, we'll be reviewing this data next week. There appears to be the same numbers, or it could cross that, because there appears to be some underreporting because we were all busy and everybody was talking about COVID, and all TB centers were being used for TB for COVID care services. We believe there would be an effort required for catching up.
Okay. Thank you, sir. There's another question from Professor Mahadev and Pediatrics. He's asking about pediatric TB. That is, he says it is a sentinel event, and is it due to undiagnosed or incompletely treated adults in the community? I think that's the question. Is pediatric TB part of the National Tuberculosis Eradication Program? I think answer is yes, because we had one speaker, Dr. Vikram from AIMS, pediatric pulmonologist, who came and spoke very nicely about the revised regimes. I remember many of my patients with extrapulmonary tuberculosis, we used to give half tablet, quarter tablet, and that kind of thing. And now with fixed drug combinations, life has become much, much easier. I think that was the other question. And sir, one more question which is coming to your mind. You were talking about TB champions. You were giving a clarion call for people to join in the efforts and contribute in whichever way it is possible. Like many programs, so like for polio eradication and all, there is a big daddy in the form of Melinda Gates Foundation and all. But things like this, which is actually going to grassroots public health levels, we hardly find any private spending on these kind of things. No? So there was a speaker who elaborated on this. I think Dr. Sunil Goyal from PGI. He spoke about quality assurance in public health in this platform, and there I think he was also raising this issue that how do we get people from industries and others to come and contribute towards grassroots improvement of public health. Sir, any comments
Yeah.
or feedback or?
There is a Government of India document and guideline. Perhaps I just shared in the slide about CSR funding that is now available, corporate funding that is available from corporates for TB elimination campaigns in the areas that have responsibility. We have several examples from Maharashtra, from Gujarat, and also from Patna in Bihar. Dr. Narayan sir will know these places a little better, where corporates have donated generously towards improvement of TB care services. And they've been kind enough to also help in data monitoring, because they need to be careful about where their money goes. So not very many, but we've got at least a dozen very good examples of corporates chipping in to improve quality of services in certain remote areas of Bihar, Maharashtra, MP. I'm not sure about Tamil Nadu, but during the last meeting, there had been a group which wanted to work to improve TB care services. There is a platform, and I think more efforts need to be made in that regard.
Okay, sir. I hope we'll find somebody in Puducherry also to support this particular program. We'd ask if Dr. Bhatt has got any questions or comments. Sir, over to you, sir.
I think, as usual, it's a good presentation. Expect a lot of information. One thing I was looking at the data, 2020, there was a fall. It also could be because of COVID, the movements became less. You said the cough and all that. So maybe people are not really able to collect or document the cases. That could be one of the reasons, I think. Because again, 2021, it has gone up. Is it like that? Because we could not go around checking for cases because COVID, a lot of restrictions.
Yes,
And
definitely.
And another thing I wanted to know was now the regime is changing and you are making shorter case, shorter duration. Complaints may be definitely better, but cure, do we see total cure, radiological cure, or completion of treatment you take as cure?
Right now, sir, there is a document, Standards for TB Care in India, which WHO has brought up, looking at international guidelines. So there we have agreed with all the professionals to use the word cure when bacteriologically the individual is negative. However, we know there are sequelae, there are residual X-ray findings that continue to be present even after years of treatment. But if the person is bacteriological negative, we'll use the word cure. But we've left this definition again to the treating physician. If they say there continues to be some sequelae, patient needs to be followed up, the patient needs to be retested after a few more months, or there is possibly that the TB is in another joint, in another area of the body, completely the treating physician could decide, but for them, we'll use treatment completed, because we are not able to document a negative report bacteriologically, either pulmonary or extrapulmonary.
Another issue is about the treatment. Like in Jipmer, when we were there, it was centralized in the pulmonary department. So the people can diagnose, but the cases have to be referred. Individually, we are not permitted to give the treatment to, probably because of the better recording and complaints. So now we ask the private practitioners to report, are they allowed to prescribe the drugs, or they have to refer to centralized centers?
Thank you very much. There has been a huge development in this regard, where as we speak, sir, the government has purchased all the TB drugs from all the manufacturers in country India. So, having said that, so TB drug is not available for sale. It's available free of market. So there are two ways of looking at it, but there continues to be, TB drugs also for sale, which cannot be done away with. But however, for the large section, TB treatment is available free of cost. And the way this has been done is every private practitioner who registers himself can claim his consultation fees as a voucher of up to 200 rupees for seeing TB patients, because TB patients wants to see Dr. X and not somebody else. So we need to respect that clinician for his clinical acumen, and there is a voucher to see that the clinician is reimbursed his cost of 200 rupees. So it's free for the TB patient. The doctor will also prescribe a voucher or give a prescription, which will be available through an enlisted group of pharmacists who will give the treatment regimen free of cost to the patient, and the program will reimburse the cost of the drug to the pharmaceutical. So this is one of the schemes that has been rolled out and is working well in some parts. There needs to be improvement in some areas, but doctors' fees, not too much, but up to 200 rupees is available. The cost of drugs is available free of cost, and to make sure that the pharmacy gives it free. Now, pharmacy needs money in order to store it. They need money to maintain their registers. So there is an amount that has been discussed and decided by the Pharmacists Association of India. So that amount of buffer is again made available to the respective pharmacies at the end of every quarter, at the end of 3 months. It cannot be done every month, but it takes about 3 months to get these accounts, and this is made now available. On the other side, if any pharmacy is reported to have sold drugs which are now under H1 schedule, then as per the Gazette notification, the license are likely to be banned. And I'm sorry to be repeating on this group, but the same Gazette notification also says if a treating doctor does not report, he gets a notice 1, notice 2, and notice 3, 6 months off the state medical register. And that's what the Gazette notification says. And
thank you very much. Very nice presentation. Back to Mahalakshmi.
Thank you very much, sir. I see Dr. Narayan is waiting, sir. Any comments, feedback?
Congrats to Dr. Anil. He's always been a leader. Of course, now he's taken a leadership in this disease, which is actually has got very wide ramifications because so many different type of professionals need to be involved. And as he was telling, that people actually do not take up this because it doesn't have much glamour. And I think what he gave as a clarion call is very, very important. Many professionals, especially the younger professionals, do need to take up this challenge. It's not going to go away so soon. And COVID has taught us lessons to that effect. And I think, and this TB fight is not going to be over. The disease is much smarter than us. And with that words, I think what Dr. Anil has contributed to not only to the specialty of community medicine, but also in general to the whole program as such, by even doing for the motivating through the IAPSM and other specialty bodies. I think he's done a great job. Congrats again, Anil.
Thank you very much. It's a deep honor to get words of appreciations. Dr. Narayan sir has been my Guruji, under whom I trained at JIPMA. And just because he mentioned IAPSM, may I just close by saying IAPSM is basically a professional association, Indian Association of Preventive and Social Medicine, which is registered at Delhi, but now we have a nationwide presence. And we are glad to share in this group that IAPSM is an official partner with the Central TB Division in the TB control program. And as we speak, we are glad to share that over 200 medical colleges, faculty from community medicine of over 200 medical colleges actively contributed in the subnational certification in the 216 districts in the past 2 months. So, and of course, we thank all the stakeholders, the ICMR especially, the NIRT, the WHO and the Government of India for making this possible, where they have reimbursed the cost of travel and an honorarium. So I'm not saying it was just free, but definitely a budget was made and they supported, and we are glad to participate in this national endeavor, and God willing, we'll be associated in the next 2 years, and God willing, we'll see into 2025 what happened, but I'll request those involved to please tune in on March 24th to find out which were the states and districts who made it, and I'm sure over 500 districts will do it next year. Thank you.
Thank you very much, sir, for ending on that very positive note. Otherwise, the figures were little scary, like when we were looking at it. And on behalf of the Scientific Forum of Arupadavidu Medical College, which is a constituent body of Vinayaka Missions Research Foundation, deemed to be university, I thank you for delivering this wonderful lecture, and more importantly, a very, very interactive session where you had answered a lot of our questions. Thank you, sir. And for the benefit of our participants, we'd again continue our journey on priority areas in public health. Next week, we have another very interesting or important facet of public health, that is how to use healthcare informatics for improving public health services. So that is going to be the talk for next week. And we have with us Dr. Sundar Raman. He's a health informatics and public health consultant. He's associated with the Jupiter School of Public Health, and he will be giving this talk. And I got him through Dr. Narayan's recommendation, and sir tells me that he is an maverick with regard to healthcare informatics. So we are in for another interesting session next week. So on these notes, we'd like to close. Danny, you have anything to say to sir?
Good evening, sir. Excellent. It was a bit of nostalgia for me. Almost went 20 years down the lane, and we are sitting in that lecture hall and listening to you.
Daniel has joined his team for combating tuberculosis.
Yes, and we look forward to more younger and more energetic people to continue, because a lot of work to be done, and we hope to be able to do it together. Thank you, Arun.
Thank you, sir.
Thank you very much, everyone, for joining us. And today is Holi, so you all, I hope that you all go and enjoy the Festival of Colors. We'll see you again next week on 25th with episode number 86. This is Dr. Mahalakshmi, Dean Health Professions Education from AVMC, signing off. Bye-bye, friends.
Have some bhang. And you can have some bhang.
Yeah.